Welcome, my dear postgraduate students, to the first class on Glide the Slide. I hope you had made some amount of homework and a diagnosis. The history that has been given is a 10-year-old boy with worsening vision. What is your diagnosis, your description, and a little bit of theory of it? As I told you, the slide should take us to the book. First, let us describe. I am finding that there is a mixed population of cells on the screen. Some are plump with round nuclei and prominent nucleoli, whereas others are bundles of wavy fibers. If I look at it very carefully, there is a third component actually that is in total disarray, haphazard. They are also fibers. So this can be a normal nerve bundle. This can be something that is resembling the Purkinje cells or the ganglion cells. So the diagnosis can be the ganglion cell tumor. It occurs within the first 3 decades of life, though it can occur in adulthood also. The sites are commonly supratentorial, that is just above the optic chiasma. That is why the patient can have a diminished vision. It can extend along the nerves into the intraorbital cavity. Another site can be the temporal lobe, wherein the patient can present with partial seizures. Central neuroaxis along the brainstem and the spinal cord cannot be exempted. Therefore, there can be a difficulty in gait or a quadriparesis. So this is the site and the presentation. Some schools of thought say it is a clear tumor. Some say it is a hamartoma. Whereas a third front says it is probably both. Hamartoma is nothing but an abnormal proliferation of the normal tissue. Ultimately, authors like Ackerman mention it to be a tumor. There can be 3 components of it: gangliocytoma, ganglioglioma, and the ganglioglioma that has got a glial component. Otherwise, it can simply be put as ganglion cell tumor. There are 3 different gradings. Grade 1, gangliocytoma and ganglioneuroma. Well differentiated, no pleomorphism, not much mitosis, etc. In the second grade, there can be pleomorphism, binucleation, etc. Even mitosis might be there. Whereas in grade 3, added to all of this, there can be, say, tumor giant cells and areas of necrosis. The word necrosis is important in any neurogenic tumor. It straightaway away takes us to the last grade. Now, what are we going to see in this? It is a well-differentiated, slow-growing neuroepithelial tumor. It is mostly benign, WHO grade 1. It is composed of large, mature, but still dysmorphic cells. In the sense, you find that there is a crowding of the ganglion cells. Usually they are all well separated, well spaced. But here there is a crowding. And the neurons also are haphazard. So when this is present, it is a gangliocytoma. And along with the glial cells, it can be called a ganglioglioma. Grossly, I find that it is a well circumscribed tumor. So much so, it has been mentioned it is a cakewalk for the surgeon to enucleate it. Surgery is a mode of treatment. It is usually solid, but can be solid and cystic. There are no areas of hemorrhage and necrosis. Look at this one. One of the diagnostic features for any neurogenic tumor, take a schwannoma and all, you find that will be glossy and glistening. Here I am finding a biphasic population. I am finding the ganglion cells and the glial cells. Sometimes there can be binucleation and neuron clustering. I find that they are all clustered together in one. So also these bundles, which is called as kissing neurons. The clinical presentation can be because of this. So this is the optic chiasma, and then there is the optic nerve to the eyes, and the tumor can be intracranial or it can be intraorbital. So what happens? I find that within the eye, there can be a compression of the optic chiasma, there can be the tumor. Or if it is going to be within the orbit cavity, I find that there is again a compression, there is a diminished vision. So that can be justifying the clinical history. Now, what are we seeing in this particular slide? Compared with the previous one or the next slide, I find that there is a pleomorphism of the cells. Some cells are large and there is a large nucleus, prominent nucleus. There is also abundant glycogen vacuolation or degeneration within the cells. Mitotic activity is increased. And sometimes I may be able to see some giant cells also. So this is atypical. So look at this one. This one is multinucleate. Look at this person over here. Here also I am finding that there is an increase in the ganglion cells, a kind of clustering or the kissing. And there are also the neuronal ones. But compared to this appears bland. There is a kind of homogeneity, large cells, large nucleus, maybe a granular or finely vacuolated cytoplasm resembling the mature ganglion cells or the Purkinje cells, which have got more of a pyramidal shape. And you can also appreciate the wavy nature of the nerve bundles, but then they are intersecting, you get it to be a ganglioneuron. So what happens in this is there is an irregular distribution of the cells. Neurons can be of varying sizes. They can have a ganglion-like profile, and the neuronal tissue is in disarray, and morphological changes can be seen. If at all it is removed and there is a recurrence, they say that it is more anaplastic in development. In anaplastic, there can be mitosis, microvasculature, there can be necrosis. In some cases, when the nerves are being involved, there can be an added chemotherapy and radiotherapy next to surgery. This is cyanotophysin that is showing positivity, courtesy ResearchGate. And the diagnosis, it says they are large cells, eosinophilic cytoplasmic granules, which are mostly lysosomal in derivation. The electron microscopy will be showing external cytoplasmic processes. Parallel microtubules can be seen. Neurite-like extensions and neurosecretory granules can be present. These we will not be seeing in the light microscope. The markers are cyanoptophysin, chromogranule, and it is negative for UN. Also, the microtubule is supposed to be positive for neurogenic tumors. So this is the one. Sometimes there can be a disease called as Lermite-Duclos disease. I am able to see a tumor. And if the students make a diagnosis of ganglion cell tumor, it is fine enough or fair enough for them. We shall glide to the next slide. And The next slide is, thanks to web pathology, it is a 69-year-old male who met with sudden death. What is your diagnosis? Description, details. See you in next class.